So, good afternoon, one and all. On behalf of IDA Bengaluru branch and K.L.E Society's Institute of Dental Sciences, I welcome you for the fourth webinar in this long 5 webinar series. On the topic for today's presentation is oral cancer and potentially malignant lesions, diagnosis and management by Dr. Subhashini A R. So, before we begin with today's session, I request our principal, young dynamic principal, Dr. Srivatsa Ji, who is sitting next to me, to please address the gathering.
A very good afternoon to everyone. It's my proud privilege today to welcome you all to this lecture. And it is also a very good feeling for K.L.E Institute of Dental Sciences to be associated with Indian Dental Association and in conducting this series of webinars. I'm very happy that our staff members, Dr. Srivastava and Dr. Prashant, being part of Indian Dental Association, have given us this opportunity. And I'm also very happy that our staff members, two of our staff members, Dr. Subhashini and Dr. Ravi Kumar, are presenting lectures today and tomorrow. So on behalf of our K.L.E Institute of Dental Sciences and IDA, Indian Dental Association, I welcome you all to this program. And I'm also very thankful for happy that Dr. Ravi Kumar will be speaking on tomorrow on malocclusion and preventive orthodontics, pediatric perspective. So thank you once again and welcome you all to this program.
Thank you, sir, for your kind words and your support. Really, our principal has been a great and immense support for conducting such programs. Recently, also, we conducted a program on CBCT from Department of Oral Medicine and Radiology, and we have got a series of programs, upcoming CDE programs from our own institute, that's K.L.E Institute of Dental Sciences. So, thank you, sir, for your continued support and guidance in supporting IDA for conducting such programs. So, before we begin our today's program, I would like to just give a gist of the programs conducted on the eve of World Oral Health Day from the IDA Bengaluru branch. These are the office bearers of our IDA Bengaluru branch. On behalf of World Oral Health Day, we had a CDE program on prevention of oral problems, a pediatric perspective, from held at K.L.E Society's Institute of Dental Sciences, Bangalore, by Dr. Srinivas L.S. These are the photographs of the programs being held at our institute. Some of the photos. And as a continued part of this program, we are having a series of webinars, 5 webinar series carrying 5 CDE points, and it's entirely online. And each program has got 1 CDE point being given by the Karnataka State Dental Council. So we completed with the 3 webinars, and today we have got the 4th program or the webinar, that's oral cancer and potentially malignant lesions, diagnosis and management. So the main aim of the World Oral Health Day was to create an awareness about the prevention of dental caries along with oral cancer. So we thought of choosing a topic on oral cancer related topic, and the best department or the best staff to speak on this topic was none other than the staff from our Oral Medicine and Radiology department. So we asked Dr. Subhashini Madam, and Madam was very polite and accepted our invitation. Thank you, Dr. Subhashini Madam, for accepting our invitation amidst your busy schedule and coming here on this platform to share your views. To just introduce Dr. Subhashini Madam. So, Madam completed her MDS in the subject of Oral Medicine and Radiology from the GDC in the year 2006. Currently, Madam is working at K.L.E Society Institute of Dental Sciences, Bangalore. And Madam is extensively involved in research that to early detection of oral cancer. Madam is also a consultant radiologist at various diagnostic centers in and around Bangalore. Apart from this, for her research, she has more than 50 publications in national and international publications, and also she has contributed chapters to textbooks of oral medicine. She has been a resource person, quizmaster, invited speaker, and also has delivered many guest lectures at various forums. Really, ma'am, we are very lucky to have you here, and I now request Dr. Subhashini Madam to please proceed with her presentation and share her views. Over to Dr. Subhashini Madam.
So a very good afternoon to one and all, and sorry for the technical issues. Thank you, Prashant, for the kind introduction. So today we shall be talking about oral cancer and potentially malignant lesions. Now, from the perspective of a clinician, from a perspective of a general dental practitioner, we shall be looking at what is this burden of oral cancer. Is it likely that a patient with oral cancer will walk into my clinic? If so, how do I diagnose it? And once I diagnose it, how do I go ahead with the management of such a patient? We should also be looking at a few potentially malignant disorders and learning how to identify and manage them. So let us begin with understanding this problem of oral cancer. How big is this problem actually? GloboCan is an organization that collates cancer-related data from across the world. And this is the data that is provided for India for the year 2020. So in 2020, there were 13 lakh plus cases that were detected of all cancers that were that occurred in India. And if we look at the various cancers, we see whereas lip and oral cavity, it is at the number 2 position. So it is the second most common cancer of all cancers in this given year. If we split this data among males and females, we see that oral cancer is the most common cancer among men. It is number 1 among men and number 4 among women. And this trend has been there for the last 20 to 30 years. The oral cancer incidence has been continually increasing, especially among males, and it is projected to increase further by another 26% by the end of this decade. And this in a country which is said to have one of the highest number of dentists in the world. If we look at, for example, my institution. So in my department, we get on an average, let's say around 500 patients, new cases per week. And out of that, almost always we have 1 to 2 CA cases per week. So if you consider this into your practice, and if you say you're seeing 500 patients in, say, for example, 6 months, it is very likely that a patient with oral cancer will walk into your clinic. So if that is the incidence of oral cancer, next comes the question of, does oral cancer actually cause death, and how many people die because of oral cancer? So this particular graph, please look at the red bars of the graph. They show us the mortality rate due to the various cancers. And here again, lip and oral cavity cancer is at number 3 position. So it is the third most common cancer causing cancer-related death in our country. So why this problem? Who is the doctor who sees the oral cavity most often? It's the dentist. And like I said, we do have a very high number of dentists in our country. Then why still we have such a high burden in our country? That is because the detection of cancer happens at quite a late stage. More than half of our patients present to a doctor only when the lesion has spread from the oral cavity to the surrounding tissues, especially the cervical lymph nodes. About only 1/3 of them come to us when it is in stage 1 or stage 2, that is when it is restricted to the oral mucosa. And if you look at the 5-year survival rate, how many of them are actually going to survive? If a cancer is detected in the stage 1 or stage 2, that is when it is only local, the survival rate is about 84%, which is quite good. When it is spread to even a single lymph node, it becomes a regional metastasis, and the survival rate drops to just about 64%. This delay that is happening, this gap that is happening between the start of the disease till the treatment that is given for oral cancer is termed as diagnostic delay. Let us split up this delay and look at why this is actually happening. So diagnostic delay is about 5 to 6 months, and it is split up into 3 portions. One is one that is caused by the patient himself, that is called as patient delay. So what happens if a patient sees something, some small change in the oral cavity, they try some home remedies, they say that, okay, it is something that will go away. They tend to ignore it until it really becomes bothersome or something, and only then they visit a doctor. So this is a part of the patient delay. Once they visit a doctor, possibly the lesion is very small, and the doctor might think of it as some other condition and treat it for, say, for example, a friction or an ulcer, or an infection for some other reason without providing a proper guidance to the patient. The last part is the system delay. Now, system delay happens when the patient has been diagnosed with oral cancer, but he has to be posted for further treatment. That could depend on factors such as financial issues, the timeline of waiting that is there for providing, say, surgery or radiotherapy or something, and nothing much can be done about system delay. what we can do to reduce the burden of oral cancer, bring it down from that #1 position to improve the oral health of our patients, is work upon the first two points that are mentioned here, the patient delay and the professional delay. So let's look at these two in a little more detail. We all know that the cause for oral cancer is either smoking or chewing forms of tobacco. And at the heart of patient delay is lack of awareness. They really do not know how harmful the products that they use are. So creating awareness in the patients and advocating habit cessation is one of the most important things that a dentist has to do. I know that it's a little difficult when a patient comes for a root canal treatment or for a bridge. If you tell them stop smoking, it's really difficult. Also, it is difficult for a person who has a habit to quit the habit, because tobacco is such a addictive substance. It's not easy to give up the habit. In such cases where patient is unwilling to quit the habit, what we can advocate is self-mouth examination. So we can tell the patient that since you have a habit, of course, the first thing is to stop the habit, but also at the same time, please look into your mouth, say once a fortnight, once a month, to make sure that there are no initial signs of the disease. And as soon as you see some abnormality, come back to the dentist. Another very useful thing that a dentist can do is a outreach program. He can reach out to community level, probably some villages, because in our country, far-flung areas, resource-constrained settings, villages don't really have an access to a dentist. Many of them are not even aware about the harmful effects of tobacco. So if we can spread some awareness in the remote areas, do some screening, that in turn would definitely benefit in bringing down the burden of this disease and go towards making India oral cancer free. The second concept of delay is professional delay, the time lag between the patient presenting to the first clinician to the histopathological confirmation of oral cancer. So how can we mitigate this problem? By enhancing clinicians' knowledge of signs and symptoms, aiding their decision to refer, by providing access to primary and secondary care services, and by defining clear referral pathways. So I'd like to share the story of this lady who is a family friend of mine. So this is a true story, and this happens in many of our patients' cases. So this lady, in the month of, I think, December 2015 or so, she developed a small ulcer on the tongue, on the right side of her tongue. She thought it's a usual ulcer which keeps coming and going. And she tried that Smile and Dentogel and other things. And she found that whenever she applied something, she was feeling a little better. Although the ulcer never really healed, but she was feeling a little better, and hence she delayed. By then, she had to go out of station for a month or so and came back in January, February. Somewhere in February, she came back and she went. And since the ulcer was not at all completely resolving, she went to the clinic. So when she went to the clinic, most of these photos are actually taken by her on her mobile phone itself. So when she went to the clinic, this was the presentation. There was a small ulcer, which obviously the dentist thought was caused due to trauma by the sharp lingual cusps. So they smoothened the lingual cusps of the mandibular premolars and the molars. But still, and they waited, asked the patient to wait for a period of 1 to 2 weeks. But still, the lesion never really resolved. It continued to become a little larger and became, changed its appearance, became slightly reddish and whitish. And finally, when this doctor called me for a consultation, this was in, I think, end of March or something, by then the lesion had already become, a white mass over there. And we called her to our college for biopsy. And when biopsy was done, it had really grown large enough to cross the midline, and even a lymph node was slightly enlarged. She was referred to a higher center. She's fine today. She underwent glossectomy. She's a singer, by the way. So every time I meet her now, her thing is like, I wish I knew, when it was a little small. I wish I didn't have to go through all the difficult process. Today, when she sings, her words are, not that clear, and she's not very happy about it. So she says, this problem shouldn't occur to anyone at all. I went through so much of difficulty. And the onus of this, part of the onus definitely lies on the dentist. So let us revise on some of the clinical features of oral cancers. The most common sites of involvement, especially in India, is the buccal mucosa, because of the habit of smokeless tobacco placement. In the other countries, Western countries, tongue and other sites, floor of the mouth are more common sites. But in India, please look at the buccal mucosa and especially the vestibule, the lower alveolus, where the patients have, we must have seen them making a mass of all the gutka and K.L.E and keeping it in the vestibule of their mouth. So lower alveolus is the second most common site, and the lateral border of the tongue is the third most common site of incidence of oral cancer. So what does oral cancer actually look like? The classic presentation, as we all know, is a mass. It seems, it appears like a growth with an irregular surface, which is quite well defined, and it is indurated, quite hard to touch. Larger areas could be involved. This is a typical presentation where we see both the buccal as well as the lingual gingiva being involved, leading to even mobility of the teeth when the bone becomes involved. The second more common presentation is the ulcerative type of squamous cell carcinoma, where we see ulcers more very commonly seen on the lateral border of the tongue, where the ulcers have a rolled out margin and an indurated base. So when we palpate, we feel the hardness, so it can grow deeper into the tongue, something like this. Some other presentations that we come across is a mass with bleeding, reduced mouth opening with another growth over here, and a small hyperplastic areas. This was actually a verrucous carcinoma that presented. And in this case, the cancer has grown so much that it has actually penetrated through the skin and has appeared. You know, this lady has neglected it for so long that it has actually involved the skin also. So the question is, I mean, the frank oral cancer, it doesn't cause much of a confusion. We all know that it's something really unusual, and we are able to make out that, okay, this is something that definitely needs referral. What are the points to remember as to when to refer such a patient? Please remember this, that any persistent ulcer, a single ulcer that has not healed for a period of 3 weeks or more, is, please put a question mark and definitely refer this patient. Any unresolved mouth swelling that has lasted for more than 3 weeks, unexplained neck lumps, which could indicate lymph nodes that are enlarged, red and white patches with pain, which may or may not be undergoing a malignant change, unexplained tooth mobility persisting for more than 3 weeks, unexplained, especially when it is accompanied by a mass that is present next to the mobile tooth, unexplained persistent trismus when there is a involvement of the facial spaces. Oral cancer leads to trismus. Sore throat and hoarseness occur when it extends to involve the oropharynx, and any other unexplained signs and symptoms of the mouth that have not resolved. So whenever we come across any such finding, do refer a patient to a higher center. So let's look at the role of a clinician, of a general dentist, when we come across such a patient. So let's say we have a patient in whom we suspect that there is oral cancer. What is the first step that needs to be done is that we need to do a biopsy to confirm that it is indeed oral cancer. Now, where and how to do the biopsy? You could call an oral medicine or an oral surgery specialist at a consultation at your own clinic and have the biopsy done. Or you could choose to refer the patient to a slightly higher center, such as a dental college near your place, or any center which will perform a biopsy, a nodal center, and obtain a diagnosis. Now, this will confirm the diagnosis of oral cancer. Now, once a diagnosis of histopathological diagnosis is confirmed, then the patient is directly referred to a tertiary cancer care center. Now, those of us in Bangalore immediately think of Kidwai. We say, okay, we'll refer the patient to Kidwai. But it's not really necessary that every patient in whom we have suspected oral cancer has to be directly sent to Kidwai, because that will increase the burden upon that tertiary center. Of course, frank cases, do refer them directly to the tertiary center, but whenever in doubt, please perform a biopsy. Once we've referred the patient, does our story end here? No, certainly not. There is a lot of pre-treatment care that a person with oral cancer needs. Before undergoing any treatment, say radiotherapy or chemotherapy, there is a need for thorough oral prophylaxis, extraction of unrestorable teeth. So all these services can be provided by the consulting dentist himself. Support through treatment is very much required for the patient, because they go through a lot of difficulties during, let's say, radiotherapy, where they develop dry mouth, multiple carious lesions, and burning sensation in the oral cavity. So all those can be supported by the dentist. and post-treatment follow-up, which needs to be almost lifelong. For any patient who has completed his radiotherapy treatment, lifelong follow-up is required, not only to treat other side effects of the radiotherapy, but even to make sure that oral cancer doesn't recur. Well, that is about oral cancer. Frank oral cancer, like I said, quite clear-cut, we can just refer them. But most oral cancers do not arise de novo. It's not that they are not there today and they begin tomorrow, but they are preceded by what are called as oral potentially malignant disorders, which are pointers to us, which are warning signs, which tell us that please look out for this. Such and such a lesion might tomorrow turn into a cancer. So which are the OPMDs, or the oral potentially malignant disorders? The list is huge. Leukoplakia, proliferative verrucous leukoplakia, erythroplakia, submucous fibrosis, lichen planus, palatal lesions in reverse smokers, lupus erythematosus, dyskeratosis congenita, lichenoid lesions, and oral graft versus host disease. Like I said, the list is huge, but today we shall be looking at the most common out of these, that is leukoplakia, submucous fibrosis, and lichen planus in a little more detail. So to begin with leukoplakia, as we all know, leukoplakia is a white patch. We all know the etiology. It is smoking as well as tobacco chewing, smoking and smokeless forms of tobacco. Now, the homogeneous, the white patch of leukoplakia might clinically appear in two forms. They are called as the homogeneous form and the non-homogeneous form. Homogeneous form is a predominantly white patch that cannot really be scraped off. It will appear somewhat like this, like a white patch that is quite discrete, that is separated from well-defined compared to the rest of the mucosa. That cannot be scraped away, and that does not disappear after stretching the mucosa, does not disappear after the cessation of the habit. Let's say patient has a habit of placement of quid, or let's say that it is because of some friction. Once we resolve all those causes, also the lesion does not heal, and that defines a homogeneous leukoplakia. So this is an extensive lesion on the tongue. Similarly, in the vestibule, most often caused due to placement of smokeless tobacco products. Non-homogeneous forms of leukoplakia appear as mixed red and white areas. So there are red areas surrounded by, marginated by white areas. So these patients, the homogeneous leukoplakia is generally asymptomatic. So that increases the role of the dentist, because then we need to, the patient may not even complain about it. So it is the dentist's onus to actually examine the entire oral cavity. Whereas in non-homogeneous leukoplakia, these patients may have a slight burning sensation in these areas. Some other forms of leukoplakia include a varicose type, where we see small finger-like projections, or small projections involving extensive areas of the oral mucosa, or small nodular projections of on the mucosa. So leukoplakia can be classified into clinically. When we look at a lesion, we can predict and say that, okay, this is low risk and this is high risk. So what is a low risk lesion? When we say a low risk lesion, the malignant transformation potential for leukoplakia is about 0.13 to 34%. And the lowest risk is for some lesions, whereas high risk for malignant transformation is for the other lesions. So which are the low risk lesions? Are any lesion that is less than 200 millimeters square in area, which has a homogeneous white clinical appearance and occurs at subsites excluding the tongue and the floor of the mouth. Any lesion which is larger than 200 millimeters square is non-homogeneous in appearance, that is mixed red and white appearance. Any lesions present on the tongue and on the floor of the mouth in individuals aged above 50 years, especially in those with a family history of cancer. If we can find invasive Candida albicans, which is secondarily infects the surface of leukoplakic lesions, if leukoplakia is present for a long duration of time without any resolution whatsoever, and leukoplakia that occurs in non-smokers, non-habitues. So these kind of lesions, all of them come under high risk for malignant transformation. So what do we do when we get a white patch, when we get what we suspect to be a leukoplakic lesion? First thing is to do is exclude other known conditions which resemble leukoplakia. Now we are going to look at some of these other lesions, similar lesions, towards the end of today's presentation. Provisionally, let's say we have reached a clinical diagnosis of leukoplakia. Then the first step is to do a biopsy. if biopsy reveals some other cause, let's say it reveals candidiasis or lichen planus, then the management of those conditions is done according to the diagnosis. But if biopsy, any biopsy for a leukoplakic lesion comes out as leukoplakia with or without dysplasia. Now, dysplasia could be either mild, moderate, or severe. So mild dysplasia or no dysplasia is considered to be a low risk lesion, whereas moderate and severe epithelial dysplasia indicates to us a high risk lesion. Now, I know the slide is a bit confusing. So let's look at the color coding over here. Anything that is white, anything that is green is a low risk lesion. Anything that is yellow and red is kind of a high risk lesion. So once we have this clinical decision in our mind that the lesion we are facing is either a low risk or a high risk, how do we manage it? So our team from our department has come up with this classification, which we have published on the management of OPMDs, all the OPMDs, and we have classified the treatment into 3 different modalities, such as the essential treatment, the optimal treatment, and optional treatment. Essential treatment refers to any treatment that is a must do for all patients, irrespective of the screening, whether it is checked in the clinic, or whether it's a hospital setting, or whether it is a community setting. This particular treatment should and must be given for all the patients presenting to us with the lesion. Optimal treatment refers to the standard treatment that must be given for a case that is diagnosed as any of the OPMDs. And optional treatment refers to the facilities that are available. If resources are available, these are advanced treatments that can be given to a patient. So let's look at the treatments for, to begin with, low risk leukoplakia. So any leukoplakia that is homogeneous, whitish in color, in, say, for example, buccal mucosa, how do we manage such a patient? So what should and must be done is the essential treatment. First of all, we start with counseling for habit cessation. Next, dietary modulation to increase antioxidants in their diet. Topical antifungals such as clotrimazole. It's been found that the thickening of the leukoplakic lesion can be reduced in many instances because there is secondary colonization with Candida albicans. So that can be improved by using topical antifungal for just a period of 7 days. If there is no improvement of that, after that, so we go ahead with a topical vitamin A application, 25,000 international units, twice daily, given for 90 days. Beyond all this, referral to a nodal center to make sure of the diagnosis and biopsy, if and when required, must be done for all patients. Optimal treatment for low-risk leukoplakia includes, apart from essential treatment, biopsy, which will tell us whether it is either the dysplasia is present and what type of dysplasia. Assuming that it is only a mild dysplasia, we can go ahead with administering curcumin extract tablets, about 3 capsules, 2 times daily. The dosage is high, and this is to be given for 6 months due to its curcumin is beneficial because of its anti-inflammatory, anti-neoplastic activity. Regular surveillance of all patients is absolutely a must. It is optional treatment is any treatment that has to be carried on if facilities are available. Let's say we can do a cytology and provide molecular level diagnosis to the patient. If the facilities are available, please do go ahead with it. Biopsy can be done, and cryosurgery and cold knife excision instead of a simple scalpel excision is less traumatic to the patient. Cauterization can be done, and laser ablation should be done. For high risk leukoplakias, that is non-homogeneous leukoplakias, how do we manage such patients? For this, the essential treatment, that is the treatment that needs to be given out for every patient, is biopsy. So biopsy is mandatory whenever we see a mixed red and white lesions, and biopsy may give out whether it is a moderate dysplasia or a severe dysplasia. Once we get that diagnosis, we go ahead with a conventional surgical excision with or without grafting. If it's a very large lesion, let's say bigger than 4 centimeters in its greatest diameter, then it may not be possible to completely excise the lesion. Then we can do a wait and watch approach to observe the lesion through a rigid surveillance. So for such patients, it is advised that surveillance has to be carried out once in 3 months, continuously over the next 1 year. For 1 year, it has to be once in 3 months. Please follow up these patients. And after that, increase in size of the lesion. Once in 6 months, the patient can be followed up over the next 5 years, and beyond that, as and when required. Optional treatment is further treatment that can be done when facilities are available, include laser ablation, electrocauterization, cryosurgery, and even photodynamic therapy can be done wherever the facilities are available. Well, that was about leukoplakia, which is possibly the most common OPMD that we come across. Another very common, potentially malignant disorder, especially in India, is all know this is caused due to the chewing of areca nut, which is not only the raw nut, but even the commercially available preparations such as pan masala, gutka, mawa, which lead to fibrosis, increased fibrosis in the oral mucosa, and lead to the known clinical manifestations. So oral submucous fibrosis tends to be a symptomatic condition, and patients come to us with a burning sensation. So the first thing that we see is a burning sensation and a slight blanching of the buccal mucosa that is present. Over a period of time, if the patient doesn't reduce the habit, then we see a continued blanching that happens, a reduction in the mouth opening because of the extensive fibrosis. There is loss of resilience. You won't be able to even retract the buccal mucosa to examine the teeth. This fibrosis can occur not just in the buccal mucosa, but even the labial mucosa, floor of the mouth, and even involve the soft palate. When the soft palate is involved, it tends to involve the uvula, causes fibrosis in the uvula, leading to a butt-shaped uvula. Patients are unable to blow the cheek, so that is because of the fibrosis, and progressive reduction in mouth opening is a characteristic feature. So the morbidity is also high with patients with oral submucous fibrosis. How do we manage OSMF? Again, following the same guidelines that we have given: essential, optimal, and optional care. Essential care that needs to be given for every patient with OSMF includes cessation of habit and physiotherapy, the bare minimum that can be given. So physiotherapy can be given by just asking the patient to bite on ice cream sticks, which can be placed one over the other, so that thereby gradually increasing the mouth opening, or simple mouth opening to be done multiple times throughout the day, and cheek blowing exercises. If they can just keep doing it whenever they see, whenever they are free, morning, afternoon, and night, you can ask them to blow the cheek, so that puts a pressure on the buccal mucosa and can aid in reducing the fibrosis. Optimal treatment includes nutritional supplements and antioxidants, and intralesional injections, which is very frequently carried out. The level of evidence for intralesional injection of hyaluronidase, 1,500 international units, is the level of evidence is a bit low, but we do find an improvement in some patients. So we give twice weekly injections of hyaluronidase for these patients. Other treatments include collagenase, imatinib, which is chemotherapeutic drug, and microwave diathermy, ultrasound, all of which can reduce the fibrosis and improve the mouth opening. So this is for patients with a mouth opening greater than 20 mm, where the OSMF itself is quite mild. Now, what to do for cases where the mouth opening is further reduced, restricted to less than 20 millimeters? Then again, the essential treatment is, of course, cessation of habit and physiotherapy. But it is the best treatment for such patients is to go in for a surgical treatment, because they usually do not respond to the medical line of management. And excision, that is fibrotomy, excision of the fibrous bands can be carried out. Reconstruction with tissue flaps can be done whenever the facilities are available. Other treatments include temporal muscle myotomy and coronoidectomy, which can aid in increasing the mouth opening. So those were two common conditions. The third OPMD that I would like to deal with is oral lichen planus. In contrast to the other conditions, oral lichen planus has no association with tobacco. It is an immunologically mediated disease, mucocutaneous disorder. About 15% of the patients who come to us with oral lichen planus also have skin lesions in the form of papular, itchy patches that are present on the flexor aspect of their arms and legs. So these patients come to us mainly with a complaint of burning sensation. There are various clinical subtypes that have been described. 3 of the subtypes are keratotic types, that is the whitish types that include the reticular, papular, and the plaque-like forms, for which many of the patients may be asymptomatic, but some of them may have a burning sensation. They look like something like this, like reticular striae that are present, Usually it is bilateral in distribution. So we can see this is the same patient, right and left buccal mucosa, or involvement of the tongue with a patch and this typical lace-like network that is present in the buccal mucosa. When it involves the gingiva, lichen planus, there are 3 other forms, clinical forms of lichen planus, which can have a mixed red and white appearance. These include the erosive type, the bullous, and the ulcerative types of lichen planus, where most of these patients come to us with a severe burning sensation, inability to tolerate spicy, hot foods. So again, it is bilateral in distribution. The striae are almost always present, and they are characteristic for lichen planus. So you can see white striae, reticular striae that are present in addition to the red areas seen. When lichen planus affects the gingiva, we see it as a denudation of the gingiva. This is termed as desquamative gingivitis and can involve either the full extent of the gingiva or separate areas in the oral cavity. The malignant transformation rate of lichen planus is comparatively lower. It is less than 5%, but there is a small amount of risk that is definitely involved, especially for these erosive lesions, for the red areas, for the mixed lesions, because also when the patients have an associated tobacco habit, it is said to increase their chance for developing a malignant transformation. Now, how do we manage oral lichen planus? It is known that lesions of lichen planus get exacerbated when a person is emotionally stressed. So psychometric evaluation and counseling forms an essential part of management. So counseling to reduce the stress levels would definitely help in bringing down their burning sensation. Typically, we start off with triamcinolone acetonide 0.1% to be applied 3 times a day for 2 weeks, or clobetasol propionate 0.05% in ora base 2 to 3 times a day for 3 weeks, and then follow up depending on the response of the patient. In other cases where the lesions are not responding to this topical application, we advise tablet betamethasone 0.5 milligrams to be dissolved in water and oral swish and spitting out that solution. This is given 3 to 4 times a day for 6 weeks. When patient can afford it, cyclosporin, topical tacrolimus, and topical retinoic acid can also be advised to the patient. Other treatments include, for optimal treatment, some other treatments. So for example, I spoke about the gingival involvement, the desquamative gingivitis. We can also provide them with a splint. Now, the splint will carry the drug, the topical drug, the triamcinolone can be applied onto the splint and the patient can wear the splint. So this will provide a greater duration of exposure to the drug for the patient and can help resolve the symptoms of burning sensation. Curcumin, again, because of its anti-inflammatory properties, has been found to be beneficial in some studies. Tablet lycopene has also been found to be beneficial. For those patients who have not only oral cavity lichen planus, but also have, say, vulvovaginal lichen planus or skin lesions, systemic administration, better to be carried out under the guidance of a general physician. 0.5 to 0.75 milligram per kg body weight for less than 10 days can be administered for these patients. Optional treatment for lichen planus, other treatments have been tried, such as low-level laser therapy. So this is a low-level laser therapy where the laser given is about 630 nanometers wavelength, and for a duration of about 10 to 15 minutes. This is given about once in 3 days for a period of about 1 month, has been found to help in some patients. Photodynamic therapy and PUA therapy have also been tried in a few studies. Well, those were the most common OPMDs that we come across in our clinics, some of the clinical features, and a few guidelines about how to manage them. But we should always remember that we need to rule out several normal variants of the oral mucosa that we need to rule them out before we come to a conclusion of come to a diagnosis of OPMD and manage. So these are yellowish papules that we see in the buccal mucosa. It's Fordyce's granules, the map-like appearance of geographic tongue, the mixed red and white lesions associated with candida. This can sometimes be confused because these patients also come to us with a burning sensation. Angular cheilitis presenting as fissures at the angle of the mouth is also another feature of candidiasis. All these need to be differentiated from OPMDs. Now, when a patient places the tobacco at a particular site, it can lead to appearance of wrinkling, which we call as tobacco pouch keratosis. This generally resolves when the patient stops the habit. So this is another case of tobacco pouch keratosis where the patient places the tobacco in the upper vestibule. A chemical burn is again a mixed red and white area where the patient is placing the smokeless tobacco in the vestibule. It can also be, these lesions are scrapable, can be differentiated from speckled leukoplakia or non-homogeneous leukoplakia. Small swellings, which have a very smooth surface, can tell us that this is definitely not a cancerous lesion. This is definitely benign in appearance. This is a frictional keratosis. Ulcers, which are shallow and typically which are recurrent, which heal and recur, again point towards a diagnosis of recurrent aphthous ulcers. Mucocele is another swelling which is bluish colored and appears on the lip or the labial mucosa. Labial linea alba is another, or frictional keratosis are some of the changes that we see along the occlusal plane on the buccal mucosa and are definitely caused due to friction and can be differentiated from other OPMDs. Now, in smokers themselves, we do see a few changes. Now, this is leukoedema, which is a white filmy appearance which disappears on stretching. Now, this disappearance is something that is not seen in leukoplakia, but a leukoedema would disappear on stretching, giving us a clue that it is not a potentially malignant disorder. The PAN encrustations, which are just encrustations of the PAN into the surface epithelium in a habitual PAN chewer. Palatal changes in a smoker due to the enlargement of the palatal mucosal salivary acini. Well, I'd like to conclude my presentation with these take-home messages. Please do perform an opportunistic screening of all patients who visit your clinic or hospital. They might have come for a root canal or a bridge or any treatment. It would take hardly a minute for you to look into the oral soft tissues, because it is the duty of the dentist to provide the best possible care to his patient, and definitely it would improve the health of your patients. Detect any oral mucosal abnormalities and refer promptly as and when required. Advocate tobacco cessation, because even a small advice from a doctor is taken seriously by the patient and will help him to quit the habit. Identify and investigate any mucosal abnormalities. Manage OPMDs as per the guidelines we just mentioned as being essential, optimal, or the optional guidelines as facilities are available. And make sure that there is a long-term follow-up for all patients with lesions. So I would like to conclude by thanking the IDA Bengaluru branch, Dr. Srivastava, President, IDA Bengaluru branch, Dr. Prashant, the CDE convener. I'd also like to thank our principal, Dr. Srivatsa, sir, for his support. My vice principal and the professor and head of our department, Dr. Praveen Birur, for his constant guidance and encouragement. I'd also like to thank all my colleagues and postgraduates for their support in presenting this presentation. Thank you everyone for a patient hearing, and thank you all.
Thank you, ma'am. Dr. Subhashini, madam. Really, it was a wonderful presentation, madam. Thank you, really, because not only from a theoretical point of view, you have shown all the clinical cases. Definitely, it has added more impact on your presentation, and it's like it retains within us for a long time. Even all the presenters felt the same. Definitely, your clinical pictures, along with your case reports, has given a very positive impact of your presentation. Thank you, ma'am.
Prashant, most of these patients are seen in our college only.
Sure, definitely, ma'am, definitely. That's one of the good point here. Okay. So, audience, if you have, people have any questions, please post it in the chat box. There are a few questions which have been posted in the chat box. So, one of the doctors has asked how to differentiate between Candida albicans, primary infection, and leukoplakia for a common person, for tongue, particularly immunocompromised person. So, in an immunocompromised person, how to differentiate between these lesions?
All right. The classic feature of Candida albicans, candidal infection, is that generally the lesions tend to be scrapable. That is, on clinical appearance, we can remember that leukoplakia is never scrapable, whereas candidiasis is scrapable. Candidiasis almost never occurs in a healthy individual. So please look for any predisposing factor. It could be excessive intake of antibiotics, denture use, diabetes mellitus, extremes of age. some feature must be there that is predisposing, or immunocompromised status that is predisposing a patient to develop candidiasis. And of course, candidiasis causes burning sensation, whereas leukoplakia is most often asymptomatic. I think these pointers would help them in differentiating between the two lesions.
One more question: whether mixed carotenoid has any preventive role for smokers, at least when leukoplakia detected?
Sorry, I didn't get you. Whether mixed
carotenoid, maybe it's like it's typed as carotenoid, has any preventive role for smokers, at least when leukoplakia is detected. Means their question is in early lesions whether it can be detected, and whether preventive for smokers, those lesions, the signs of prevention.
Right. Okay. So carotenoids, yes, definitely it does help in the epithelial maturation and improves the lesion. But in addition to that, there has to be habit cessation. Without habit cessation, it will not really help. But carotenoids can be used for habit cessation. Yes, it can be used for these patients, for smokers, definitely.
Okay. So one more question: is lichen planus common in those having denture bridges or dentures? Among
denture
the
use per se may not lead to lichen planus. The etiology of lichen planus is not directly related to our denture, and I wouldn't say that it is more common, but it can occur. It can occur, but it is not really a predisposing factor for lichen planus. Candidiasis, yes, but not lichen planus.
Okay. One more question: how PUA given in the mouth, what care should be taken during the therapy? How PUA is given in the mouth, and what care should be taken during the therapy?
Okay, PUA is a more of under research kind of a treatment where, see, basically we administer a light sensitive drug to the patient, and we use the ultraviolet light. So there are a lot of side effects that need to be taken care. The patient needs to be actually hospitalized. He needs to be examined. There is continuous care that needs to be given to the patient while we are administering the PUA therapy. It would really be difficult to do it in a private clinic kind of a setting. It needs more care. The side effects need to be examined. The patient should not go out into the sunlight. It's a photosensitizer that is given.
Okay.
Yeah.
So one of the doctors has requested, can you show the slide of risk factors? Actually, the doctor wants to once again have a glimpse of that slide of risk factors. Risk factors.
The low risk and the high risk lesions.
Okay.
Okay, then I'll just give me a minute. I'll just share that.
Okay. If not, you can send a screenshot to us. We'll put it in the groups.
Okay. Yeah, I think that would be better, Prashant.
Okay. Ma'am, on a general point of view, from general practitioner's point of view, because this program, what we conducted, World Oral Day, it was an initiative from Ministry of Health and also from the IDA, because their major concern was detecting of the early oral cancer lesions by general practitioners. So this problem we also face, because when a patient comes to the clinic and as soon as we see a white lesion in the mouth, then we may become panic, or patient may become panic because of the incorrect diagnosis or maybe inappropriate knowledge about the lesion. So how to deal with this case? How the doctor should behave with the patient in such cases? What knowledge you should impart to the patient, and what courage you should give to the patient to go on with it? Can you please add on those points, ma'am?
All right. So whenever we see, I'll take them in two parts. Like, for example, it could be an OPMD or it could be a frank cancer case. Let's say it is an OPMD lesion. Then we definitely need to do a biopsy, like I mentioned, and then determine at what is the level of risk for transformation into oral cancer. Now, depending upon that, we can advise the patient for cessation of habit and further referral and surveillance and all that. So if it is a frank cancer case, if you feel that, okay, this is something that is, like I showed you some of the images where we are quite sure that it most probably is an oral cancer, there is no need to make the patient panicky, because oral cancer can be managed. The morbidity is a little high. Mortality, if it's local, regional, still we have very good referral centers, very good cancer surgeons who are available. treatment of oral cancer, that there is a definite protocol, everything can be managed. So please fill the patient with hope and positivity, and send the patient that, go ahead and get the treatment done as fast as possible. The important thing is to be treated early and as soon as possible. So if it's a very frank case, you need not do a biopsy. You can refer directly to a tertiary care center. If it is a doubtful case, perform a biopsy and then refer the patient to a tertiary care center.
Okay.
I hope that was the concern.
Yes, yes. One more question. What is the difference between frictional keratosis and lichen planus striae?
All right. So frictional keratosis, the classic feature is it would be along the occlusal plane. You can ask the patient to just open and close, and by the biting, we can make out the position of the lesion. Frictional keratosis generally extends only along the occlusal plane and should not extend beyond it. Yes, it can appear to be linear. Reticular lichen planus will have striae. The most common sites are the vestibule, the lateral border of the tongue. These are sites not along the occlusal plane, because buccal mucosa is a site of involvement. But make sure you're checking the vestibule of all the patients, the lateral border of the tongue, the gingiva. It tends to extend onto gingiva. That will never happen if it's a frictional keratosis.
Okay. One more last question, I think. Dr. Suresh Babu has asked an excellent question. Colgate had an early stage cancer detection kit. Is it helpful in clinical practice?
Early stage cancer?
Detection kit. Colgate had an early stage cancer detection kit. Is it helpful in clinical practice?
Colgate has come up with some... I'm not really aware of what is there in the kit. Is it an adjunct agent? Is it diagnostic toluidine glue? I'm really not sure if...
Okay, just adding on to that question, just my point of view also. Recently, I noted one of the patient as a general OPD checkup in one of the clinics or one of the referral centers. They have done screening of oral cancer for a normal patient also, regular patient. Is it advisable? Means that is the trend that's being picking up now in the general practice. For the regular patients, how we advise on OPG, now they are advising a screening of the oral cancers. Just I had a report in my hand of one of my patients, so I was just looking after that report. So is it advisable or how to go about with it, or for really risk patients we should advise?
Yeah, it is definitely advisable. It is definitely advisable. Why? Because it provides us an opportunity to look at the oral cavity in its entirety. We are able to check the entire oral cavity, because many of these lesions are asymptomatic and they are really small when they actually begin. So they might not be visible. They might not be actually causing the patient some harm, or they may not even know that there is something. So definitely a dentist intervention is required at the initial stages, firstly. Secondly, it can also lead to an awareness in the patient. You can tell the patient if they have some habit, not only them, their own people, like say their family or anybody known to them has an adverse habit. So reduce the habit, cessation of the habit, at least an indication towards that habit. Definitely screening, I would say it has to be done for every patient who comes to the dentist.
Okay, so thank you for all your valuable inputs. Definitely, it's going to add a lot of weightage to our clinical practice, definitely. And on behalf of IDA, I request you to please take this, accept this certificate as a token of appreciation.
Thank you. Thank you.
We're going to send you the hard copy later. So the ultimate moral of today's presentation is to be aware of the white lesions or the early cancers, detect it early so that a patient can go on with much prevention. As we tell, prevention is better than cure, and it can be cured at later stages also. So that is what Madam has told today. So thank you, Madam, for your excellent presentation, which has added a good clinical impact on us. Thank you, ma'am. Thank you on behalf of IDA. I also thank our principal, Dr. Srivatsa sir, who was here to welcome the audience and to address the audience also. And I thank our president, Dr. Srivatsa, who is sitting here next to me, who has been the support for conducting the such various programs. We have got a number of programs coming up in the next few days. Before we end, I request Mr. Sunil sir to please share the screen.
Yes, sir. So I will start straight away what I should have started at the beginning. So greetings to all of you. So healthy smiles matter. So we'll come straight away to the inspiration stage and then the smile research. So here there is a concept called baby elephant syndrome. So if you have seen the Kedda operation, they will catch these baby elephants and tie with a chain. However, as the elephant grows, they will replace that chain with a rope, but still that elephant won't escape. The moral of this story is that we should unchain ourselves from our beliefs, laziness, fears, or any other emotions that is holding us on to that peg of inertia, which is preventing us from growing up from that baby elephant. So this is called the phenomenon of baby elephant syndrome, and inspired by these sort of important things that happen in nature, we at Group Pharmaceuticals are dedicated to providing the best of oral care and healthcare products, including the first time in India products, which we have got through the various relationships we have, such as with Imperial College London, Columbia University of New York, and also the different organizations such as K.L.E, Manipal, and JSS, with whom we have running relationships for various research activities. So continuous improvement is definitely in our own DNA, and that's why you get some very good classic products which are constantly patronized during the chairside procedures or before or after the chairside procedure, including that of Pediflor Kids, which is also a very popular one, and Densive now, which has come for the clean and aseptic dentures. It's a denture cleansing tablet. So the world-class manufacturing facilities with all the important certifications is available. So this is why we request you to kindly patronize Group Pharmaceuticals products. Let us see the smile research. If you see here, in all these cases, there are girls who are smiling. Some of them are having a good smile. Some of them are having a no smile. So this smile has been researched at the University of California, Berkeley. And they studied the class photographs of all the smiling children or people in the Mills College. Some girls smiled genuinely and some girls did not smile genuinely. The genuine smile is called as a Duchenne smile, whereas the non-Duchenne smile is a social smile. Researchers tracked down these women for 30 years and they were surprised that those genuine smilers had happier lives in terms of marriage, well-being, and career. So definitely we salute the smile creators, and that is the dentists, because they are making you confidently give that Duchenne smile which reaches up to the eyes. So here you can see the contrast between the social smile and the Duchenne smile. And this is a typical social smile where the air hostess welcomes you without giving that actual smile, namaste, welcome, and you get taken in by that. Well, that is just a social smile, not a original smile. Here we have got Julia Roberts, who is giving you dazzlingly attractive smiles. One is a Duchenne smile, one is a social smile. So importance of smiling is that it reduces the risk for depression. So definitely you should visit the dentist because he is going to make you smile more confidently. Smile is defined as a facial expression in which the eyes brighten and the corners of the mouth lift slightly upwards, and it expresses amusement, pleasure, approval, or sometimes scorn. But again, in a little comical way, smile is a facial expression implemented by girls to kill and enslave entire populations. So that is just as a joke which has been said. Nurses' study has indicated that a genuine smile can do wonders because this conveys acceptance, builds trust, and establishes interrelationship also. So nurse with a smile definitely is going to radiate positivity, create trust and hope for effective interpersonal relationship. The entire smile psychology as well as the biochemistry has been studied, and it is very clear that smile will help lower the cortisol level to boost the immunity, control the blood sugar, blood pressure, regulate the metabolism, and enhance the memory function also. So salute to all the dentists who make us and enable us to smile very confidently in our social living. So smiling wonders in society are all thanks to the dentists. Now comes the dental arrow tree, and I request Rupa, who is sitting with my laptop, to look into the chat box and see who will give the correct answers first. So the fun quiz will start immediately. So everybody keep your fingers ready because fastest finger first. The one who types the correct answer first will get the gift hamper. The first question, acclaimed Denta question. you can see a man in this picture who is alone. He is very stressed and he is suffering dental sensitivity and GERD. I don't want to elaborate GERD. You would be knowing what is GERD. I'll elaborate it while giving the answer. But GERD is popular. What is the cause of his dental sensitivity? So which is the cause of his sensitivity? The clues are there in the question. He is old. He is having a depression type and he is suffering from GERD. Yes, any answers? Yes, perfect. Dr. Maitri is very, very smart. Again, it has come fast. Yes. Erosion is the correct answer. Definitely, you can recommend our toothpaste also for that. So sensitivity due to GERD as well as it's the acid erosion. So first answer goes to Miss Sailesh Madam, Dr. Sailesh Madam. She is a hat-trick winner. 3 times she has won. Congratulations. Tomorrow you have one more chance, madam. Now we'll go to the next question. The second question which will come. Okay, by the way, these are the 4 reasons why sensitivity, discomfort and pain will occur. Now, please write down the problem that you can see in this orthodontic patient. I don't want to elaborate more. It is very clear. You please write down what is the problem with this orthodontic patient. Madam, what are the answers? Okay, Dr. Kamla Madam is very fast this time and she has recommended that this is a patient with white spot lesion. She gets the gift hamper for the question number 2. So we have Dr. Kamla, who is a repeat winner. So this time she is getting the second gift hamper. Now we will go to the third and the final question. Let us hope some other breakthrough finalist answerer will be there. The question 3 is, Amflor, by the way, is used for white spot lesions. Okay. Name the main bacterium causing the preschool children pediatric tooth decay. Name the main bacterium which causes the preschool children pediatric tooth decay. Please type the answer. Any answers are coming, madam? Name the main bacterium which causes the preschool. Yes, Streptococcus. Okay, mutans. Okay, ಬೇರೆ ಯಾವುದು ಬಂದಿಲ್ವಾ ಉತ್ತರ? No other person has answered. Okay, no other answer is there?
Sir, lactobacillus ಇದೆ, E. coli ಇದೆ.
E. coli ಇದೆ, but main bacterium is Streptococcus mutans. We were expecting that. Okay, we'll give it to both the people. That is Dr. Rekha Shetty madam and Dr. Sonia. Okay, so you please make a note of both the names, madam. So we will send to both. So yeah, we'll give it to both. So Rekha Shetty madam as well as yeah. Okay, so that was the interesting session here of the quiz as well as something on smile research. Thank you very much for patronizing this entire proceedings. So I request Dr. Prashant sir to take over.
Yes, sir. So thank you, Mr. Sunil sir, for conducting an exciting quiz round. And once again, I thank all the audience for your wonderful wholehearted participation in both the webinar and the quiz. And we'll meet tomorrow once again at the 2 p.m. And tomorrow's session is on prevention of malocclusion from the pediatric perspective. And speaker will be Dr. Ravi, who is a pediodontist, who is going to speak on that topic. So once again, I thank all the audience and thank speaker Dr. Subhashini Madam also.
Yes, thank you very much, sir.
Thank you.